development of knowledge can be at two levels. It can be knowledge of the health professional who uses the tool, or knowledge on the part of the person who is asked the questions on our Elder Abuse Suspicion Index. When we developed and validated our tool, we found that we asked the doctors who were involved in the study what impact using the tool had on them. And the most common thing that we found was that the doctors said that the process of asking the questions, because of the way they were worded, because of the limited number of questions, because of the ease of asking the questions, the process of asking the questions was a part of the education for them about what elder abuse was. Because we had one elder abuse question for each form of abuse, so that if you asked the questions, you immediately got a sense, a gestalt, of what elder abuse was without having to go to the journals, go to a website, read a detailed amount of information. And the training of physicians today is very much focused on bottom line, rapid access to information. So that anybody who uses the tool, if they're not familiar with elder abuse, the tool is going to give them a sense about what elder abuse may look like, and optimally, as clinicians practice, they'll be on the lookout for these features, and it becomes an added benefit. Not only do we have the potential perhaps to identify victims of abuse, but we have the people who do the inquiring learning about elder abuse. That would be knowledge number one. Knowledge number two is that a more recent part of our research was to see whether our tool could be self-administered. That is, could you ask a senior to take a sheet of paper with the questions on them and feel comfortable asking answering the questions themselves effectively. We demonstrated that this was, again, easy to do, rapid to do, that seniors in English, in French, in all age categories, in all socioeconomic groups, and all educational levels had no discomfort with any of the wording and no difficulty in comprehension. And we followed those findings up with asking them about what learning had taken place in the context of answering the questions. We asked them to evaluate their knowledge before and their knowledge after asking the questions. The knowledge increased for all groups. I think what the tool does is it sensitizes in the target group that I'm most interested in, and that is physicians, to the presence of elder abuse as a important thing to be on the lookout for, and to hopefully get physicians to question their knowledge of what elder abuse is and the implications of it. One would hope that our tool is something that physicians see as useful in their practices, and they will want to use it, either as a routine screening of elderly, or when they have a level of suspicion, they're worried about something, that they ask the questions. At the present time, we do not have any data to show what kind of uptake the tool has had in the hands of family doctors for whom it was intended. In a collaboration that we were extremely fortunate to have with NICE, the National Initiative for Care of the Elderly in Toronto, with funding from the New Horizons for Seniors program from Health Canada, we were able to convert our tool into a pocket card, a mini brochure that it looks like this. Through this collaboration, this bilingual English-French pocket card has been sent to 24,000 family doctors across Canada. We do have some sense, based on our comparisons, of the outcome of using this when a doctor administers, family doc administers it, and a patient self-administers it, that in fact there may be differences in response based on how the tool is administered. Meaning, if a doctor administers the tool and the doctor is well known to the patient, and the patient is trusting of that doctor, and one assumes and hopes that over time one establishes a supportive and trusting relationship in the doctor-patient encounter, that the doctor asking the questions may prompt a patient to be a little bit more open in the response than they might otherwise be just putting a yes or a no on a piece of paper. Because patients over time do become accustomed to answering questions with their doctors that they wouldn't necessarily respond to with other people.